Hello, hello, hello. Welcome to the Nation Leadership Forum. Tonight, we're not at the Nation Center. In fact, we are at the AMREF International University. I am your host, Olive Burrows, for the duration of this conversation. I am not alone. I am joined by quite the esteemed audience around me. Ladies and gentlemen, what are we doing tonight? We are building back better. We are building back better. Yeah. We're building back better. We're building back better. Resilient health systems. Yes, ladies and gentlemen, we know the COVID pandemic sent us all into a tizzy. Some of us were afraid to visit health centers. There was a restriction on cross-border movement. There was a curfew in place. What happened if you got sick at night? We had the whole issue with the PPEs. It should not be a life and death decision for our doctors and our nurses, our clinicians, to go to their places of work. So tonight we're discussing what happens should there be a resurgence. What happens if we get another pandemic? They say, fool me once, shame on you. Fool me twice, shame on me. So as I said, I have an audience, and as is our custom, we also have panelists on board with us tonight. Allow me to introduce them. In fact, we have one who's coming to us all the way from Ghana, Dr. Ama Feni. We are glad to have you. Now, her credentials are quite lengthy, so allow me to refer to my notes here. Now, Dr. Ama Feni is a senior research fellow with the Institute of Statistical, Social, and Economics Research at the University of Ghana. Currently, she also serves as a commissioner on Africa's response to the COVID-19 pandemic and initiative chaired by the President of South Africa and supported by the Africa Union. We also have our very own Professor Edwin Barasa with us tonight. He's also joining us virtually. He comes in from Nairobi. He is the director of the national program at Kemri Wellcome Trust. Is it Wellcome Trust in Nairobi? Professor Barasa, I expect you to help me with my pronunciation there. I hope I got it right. He has extensive experience in health economics and financing, especially in Kenya and sub-Saharan Africa. And he's provided health financing advice to the Kenyan Ministry of Health and played an important supporting role in the reform of the National Hospital Insurance Fund and the Kenya Health Benefits Advisory Panel. So, Professor Barasa, we're glad to have you with us. Let me catch my breath. I have two other panelists with me on stage, as I would say in studio, on stage with me tonight. We are joined by our host actually tonight is Professor Joachim Osur, and he is the VC of this esteemed institution and is also a public health specialist, and I did say he's the VC of AMREF International University. Next to him, the other lady with me on stage is Dr. Nazila Ganatra, and she is the head of department, National Strategic Public Health Programs of the Ministry of Health, and in her current role, she coordinates activities across the National Strategic Public Health Programs, which includes the division of a national malaria program, the National Tuberculosis, Leprosy, and Lung Disease Program, as well as the National AIDS and STI Control Program, and the National Vaccines and Immunization Program. Happy to have you with us, Dr. Nazila. Prof, thank you very much for joining us tonight. Dr. Feni, Prof. Barasa, thank you all for being with us. And thank you to my audience. Hello. Hello. The hashtag for those joining us virtually is Build Back Better. Better, all right? We're building stronger, resilient health systems tonight. So do take part in the conversation. We'll be taking questions from the audience and from you at home, at work, in your car, stuck in traffic. Whatever you're doing, we're ready to engage with you. All right. Now, I think all protocols, no, I have not observed all protocols. Also with us in the audience is Dr. Willis Akwale. This gentleman, I'm sure, is no stranger to many. At many a press conference from Afia House, he was tasked with a number of questions. So I'm sure even tonight he'll be happy to answer a few. So he is the chair of the COVID-19 Vaccine Task Force. Dr. Akwale, thank you for being with us tonight. So shall we give them a hand clap? Thank you very much. So, Dr. Nazila, let's just get straight into the business of the day. As I said at the start, a number of us were afraid to even step outside our front doors, let alone visit a health center. So we have a number of targets in terms of TB, in terms of malaria. I've seen AIDS. All of that falls under your portfolio. How were these targets affected? How were these programs affected? You know, we saw reports of concerns over supply of ARVs. PPEs was a real issue. So perhaps you can paint a picture of where we are coming from before we look at where we are headed.
Thank you very much, Olive, for that question. And I'm really happy to be here today. Let me start from the beginning. We are talking about health systems, and perhaps our audience, maybe here, really do not know what health systems really means. So just to break it down for them so that when we are having this conversation, they can know exactly what we're talking about. So health system, we have health system building blocks, and majority of them will start with the leadership and governance. And I could probably start by elaborating each of the systems and how we were able, or we were able to improve it. So one of the building blocks, sorry. Thank you. So one of the building blocks is the leadership and governance components. We have the service delivery, we have human resource for health, we have the financing aspects, we also have health informatics, infrastructure, supply chains, and then research and development. So I know I've added 2 more from the WHO, but just to make it easier for all our audience and at home and here as well. So I'll start with the beginning. At the beginning, we know that the COVID-19 pandemic was declared a pandemic in March by the WHO, and also that we got our first COVID case in March, specifically on, I think, March 13th. So that is when this thing happened. However, prior to that, we had the formation of the National Emergency Response Committee, which was actually an executive order by His Excellency, and it was to be chaired by Cabinet Secretary, along with all other ministries within the government. So this really important committee was tasked to come up with mitigation measures way before we actually got our first case. From that, we also had the National Emergency Response Command Center, which was really monitoring what was going on. We also had the National COVID-19 Task Force, which was actually chaired by Madam PS, Ms. Susan Muchache from the Ministry of Health. And it had a lot of stakeholders who were, of course, in that committee, including academia, various partners, civil society, the technical people. We were all just brainstorming day in, day out on what would be the mitigation measures, how would we really approach this.
Okay,
so
but you were at the health centers, were you not?
Yes.
So
yes.
What were things like for you there at the time?
So at the health facility, it was at that particular point in time, I was working in a health facility, and all of a sudden, you know, when the first case of COVID was reported, everything went silent. The hospitals were clear. You wouldn't see anyone around. Outpatient services, I mean, they were being offered. However, I think people were panicking because of the, you know, the fear of actually getting the COVID-19. Also, there was the lockdown, and that really impacted the patient in that maybe some of them did not have jobs and therefore could not actually commute all the way to the health facilities. Some of them were really far off and needed to visit maybe a particular health center, and that was actually a challenge. But on the other side, also from the health facility point of view, there were also some challenges. The health some of the health facilities were actually really focusing on how to, you know, treat the COVID-19 patients. Healthcare workers were also repurposed sort of to go to respond to that. We also had supply chain challenges due to COVID. Most of our items, especially the PPEs, were being imported at that time, and therefore we had challenges for that as well. So, you know, health workers would also probably feel that they're not really safe enough, if they do not have those basic things. However, that really changed because then COVID-19 task force had many other subcommittees, and as I had mentioned earlier, they had so many stakeholders really looking. It was a multi-sectoral approach on how to really fight this, because it's a first thing. It's a first time Kenya was actually seeing a pandemic, and also globally, it was something that really caught us not unawares, but it was a surprise.
Yeah.
So one of the subcommittees was maintaining essential services, of which by then I was already at the Ministry of Health, and it was being chaired by the Ministry of Health. There were also sectors, other sectors, private sector. There was the partners. There was the technical people. There were also specialists. For example, like dentists, pharmacists, gynecologists.
So basically what I'm getting for you is forewarned is forearmed, because then we had to scramble to put together a response, more or less, although you did brilliantly in my estimation. But let's get a sense of what the situation was like in Ghana. Dr. Feni, perhaps you could paint a picture for us when the COVID-19 pandemic hit. How were health services impacted?
Thank you very much. And as I listened, I realized that we did similar things and we had similar experiences. We saw the government stand up and take leadership of the pandemic response. Again, empty hospitals. For the first 3 weeks of March, when COVID became the buzzword everywhere. So those who had to even go for routine checkups did not show up at the health facilities, and it was not just the patients not going to the hospitals. It was the providers also saying, we don't have enough PPEs, we don't feel safe enough to offer services when we are also at risk. We did lose a few number of our providers, our healthcare workers, and so yes, the government got in the private sector to manufacture PPEs locally with our own industries, moving from regular production of their products to produce PPEs, and so we had some of our industries who produce alcoholic beverages quickly moving on to produce sanitizers, for example. So yes, it was worrying, especially looking back, that people who died from hypertension, for example, those deaths could have been avoided if they had the opportunity to continue to go to the hospital, even when there was the COVID pandemic. So again, we're looking back and we're looking forward, and we're thinking about strategies that we need to put in place at the primary healthcare system to allow routine services to continue, at the same time equipping our public health centers to deal with a pandemic. Yes, we've learned lessons, but we've seen courageous workers, doing a lot of good within the communities, community health facilities, providing care, checking up on patients, and as Prof was speaking, I was thinking about telemedicine. When COVID was such a big issue, I remember that there was a question about why don't we invest in telemedicine? And the key question was, how many people have access to the internet? How many people have access to the smartphone where they can use their cameras, for example? So we see glaring gaps within our societies. Those who have and those who do not. Those who really need the care when they most need it may not have access if we decide to invest in particular interventions within our healthcare system. So really, COVID has been a wake-up call for us. But we've seen the government invest in the healthcare workforce. We had to recruit over 25,000 healthcare workers when the pandemic was at its height. So we've seen changes, but we need to do more. We cannot sit back and say, yes, we've invested in COVID-related activities and it's okay. We still are dependent on external financing. And that to me is so worrying. Okay. I'm sure Prof. Edwin Barasa will tell you, you cannot finance a health system with donor funds. We really have to look at how we can have internal measures to always have enough to fall on. eventually we had to have a lockdown in 3 major cities in Ghana. And believe me, that 3 weeks of the lockdown made all of us realize how dependent the whole society was on, I mean, the informal sector couldn't work. People were just desperate. I haven't seen Ghana at such a standstill, and what it meant to those who have to go out daily to make a living.
Okay. So I think you mentioned,
so
Prof.
These are some of the things we had to go through here as a country.
Prof. Barasa, this question has not come from me. It has come straight from Dr. Feni. And she talked about how our health systems cannot be financed or continue to be financed primarily by donors. So, Prof. Barasa, what do you have to say on that subject as far as lessons to take forward as we move forward? What needs to happen?
Thank you very much, Olive, for that question. I mean, it is indeed true. I mean, one of the challenges that we are facing as a continent generally is the fact that health hasn't been prioritized in terms of investments and in terms of funding. So what you have, for instance, is that across Africa, government expenditure, as a share of country GDP is about 2%, which is quite, less than half of what is expected, of what is the benchmarks that have been set, which is about 5%. And so the implications of that is that then country financing systems are troubled by two things. One, there is a heavy reliance on donor funding, and we know that donor funding, number one, is not sustainable. Donors have expressed an interest to transition out of supporting African countries over the next coming years as African countries move towards middle income status. So in the long term, it is not sustainable for us to rely on donor funding. The other thing about donor funding is that whoever pays you determines your priorities. And so donor funding tends to distort health system priorities. The other challenge with underfunding of health systems is that then African health systems get most of their funding from out-of-pocket payments. So on average, African countries and Kenya, for instance, gets between 20 to 30% of its healthcare funding from payments that households and individuals have to make when they visit a health facility to seek care. And again, that presents a number of challenges in the sense that people have to forego other basic needs, such as education, food, and so on. And we know that such healthcare payments push people into poverty. In Kenya, for instance, such healthcare payments push about 1 million people into poverty. How is this, when you think about, so these are problems that we've always had, but why are they relevant within the context of a pandemic? When COVID-19, hit, Africa and Kenya, there were quite a number of good things that African governments did and the Kenyan government did. One is to sort of respond quite promptly, showing leadership. There was quite, there's a lot of visible leadership that was shown in some countries, including Kenya, for instance. There was a sense in which, the COVID-19 restrictions and policies were guided by, scientific evidence, which is a good thing. And there has been wins, such as, mobilization of the vaccination campaign and so on. Okay. But you have to remember that all these efforts are dependent on the underlying health system. And when you're underfunding your health system and when you're relying on out-of-pocket payments, then it works against your sort of pandemic response initiatives. Okay. So you want people to get tested, you want people to access healthcare, but they can't pay for it, which presents a challenge.
And I think that's part of the reason. The president himself has acknowledged that sometimes when you get a sick person in your family, it can bankrupt you. And I think that's why there's been this push towards universal healthcare, UHC. So I'll bring you in, Prof. Osur. You're the host, so I come to you last. But a lot has already been said. Dr. Feni has talked about our building capacity, building the capacity that we did as far as manufacturing our own sanitizer, manufacturing our own PPEs. But something else that has also come up is the question of donor funding. These countries now have their priorities as well. The economies have been impacted. So what did you hope you would see happening now that we believe we are out of the thick of it, that is not happening? What do you want to see happening?
Yeah, thank you very much. And let me start by welcoming everyone as a part of this university. We appreciate your choosing to use our university for this occasion. We have learned a lot of lessons from COVID, and I hope that health system will never be the same after this. There are a few things that I hope would be happening, taking it from your question. If you look at the people who are worst hit by COVID, they are rural communities. They are people who earn little money, low-income earners in cities. They are girls, adolescent girls. There are people who already had some illness that just needed something to tip them off into severe illness and death. What is common about all these people is that most of them get healthcare from the primary healthcare level, either at the community level with a community health worker, or at the dispensary level, or at the health center level. And they are the majority in Africa. They are about 80% of Africans. That is where they are. And they were the worst hit. Why were they worst hit? Because even before COVID started, there was already inequality. They were already predisposed to not accessing healthcare. We have first to deal with the issue of inequality if we are going to succeed in future. Inequality in access to care is a big problem. And in fact, in Africa, there are two distinct health systems. Yeah? I know we have been told what a health system is. But take two people. Take someone from a rural community or a slum area of Nairobi, and someone like me. If we both have cancer, what is the pathway? Most people who earn well are likely to start with a high-level private hospital, then go to London or South Africa or some other place. They have their own system. The rest of the people, the 80% we are talking about, will go to the nearest, will talk to a community health worker, go to a dispensary, be misdiagnosed because they don't have facilities down there, end up with overt disease and die very early. So we have two distinct, more or less, health systems, one for the poor and one for the well-to-do. And this is the problem we have to deal with, inequality in access to care. And why is inequality there? It is because of social determinants of health. You know, you find yourself born in a rural place or in a slum area. You don't have good income. In other words, it is an injustice that because of your social status, you end up falling in one health system or the other. We have to deal with that as a continent if we are going to succeed in future.
Okay.
And the other thing I've learned during COVID, so I'm not giving you answers to how we deal with it, but I think governments in Africa have to deal with the issue of inequality in access to care.
And I think we'll delve deeper into that.
We'll delve deeper into that.
Yeah.
And the other thing I wanted to say that we've learned from COVID is the multisectoral approach, which I think the Ministry of Health in Kenya did very well. What does it teach us? Health does not belong to the Ministry of Health. And we can achieve health if we stop thinking of health as a Ministry of Health issue and have health in all ministries. There were times during COVID that we went into communities because we work across Africa, SAMREF, and they said, we don't want to hear about COVID anymore. We want food. We are hungry. There are times we closed schools. And people were asking what we do with our children. And some ended up getting married early. Some ended up with unwanted pregnancy. Some ended up, going into drugs. So health must now be seen, post-COVID, what we have learned, as a multisectoral issue. And we must ask ourselves, how do we make sure that the Ministry of Agriculture, that food security issues, transport ministry, and all these other people are working towards a better health for everyone.
Okay. All right. So we are heading into a break, but Dr. Akwali, I see you taking notes. we'll come back and get your comment on what has been said so far. Of course, Dr. Feni brought in the issue of we're told there's telemedicine for those who cannot access their health service providers, but how many people have access to that, to a laptop or a phone that has internet connection that can grant them access to a doctor, and can the doctor on the other side, maybe working from home, understand them if they don't speak Kiswahili or English? So issues of inequality indeed are something that we really need to seriously discuss, and we will delve deeper into on the other side of this break. My audience, we are building back better. We are building back better. We'll be getting a question from the audience on the other side of this break as well. Keep it tuned. You're watching, listening to the Nation Leadership Forum.
How was your day? Busy? Okay, if he really has to know, let's start with hot, nasty, fast, furious. Ooh, that's gotta hurt, but it's all cool. When cooling down is easy, this easy. Nice. You even took it with a smile.
What about yours?
For an exclusive fragrance experience, try Nivea Men Deep Impact Body Lotion with a long-lasting woody fragrance, deep moisture, and a fresh skin feel. Make an impact with Nivea Men Deep Impact. Nivea Men, it starts with you.
Guys, lipstick is for mommy, not the wall. I said pick one each, one. Children, they are cute no matter what they do, but there is nothing cute about fever. Panadol Baby and Infant starts to work on fever in just 15 minutes. Trust Panadol Baby and Infant to work on fever fast, to bring back their cute smiles.
Let's get straight to it. Ready for whatever. We gon' ride. Line them up. Let's go toe to toe. Tell them pick a side. Put in work. We don't play no games. Watch him running high. Savage mode. We gon' keep it G. Yeah, you know.
When cooling down is easy, this easy. Nice. You even took it with a smile.
What about yours?
Madam, si unanukia poa kama asubuhi fiti.
Na nitanukia vizuri hivi kutoka asubuhi hadi jioni. Juu with new Ariel Lavender, nitabaki fresh siku nzima. Msafi na mwenye harufu ya kuvutia. New Ariel Lavender, usafi fresh wa kukawia kwa muda mrefu.
Yani ni usiku na bado unanukia vizuri tu kama ngware.
How was your day? Busy? Okay, if he really has to know, let's start with hot, nasty, fast, furious. Ooh, that's gotta hurt, but it's all cool. When cooling down is easy, this easy. Nice. You even took it with a smile.
What about yours?
At the first sign of pain, you need a solution that you can trust. Try Panadol Advance. With Panadol's Optizode formula, the tablet absorbs quickly and starts providing fast and effective pain relief you can trust. Try Panadol Advance.
For an exclusive fragrance experience, try Nivea Men Deep Impact Body Lotion with a long-lasting woody fragrance, deep moisture, and a fresh skin feel. Make an impact with Nivea Men Deep Impact. Nivea Men, it starts with you.
Matthew! Baba aliita Bahati Matthew. And in our usual nature of politicizing everything as Kenyans, haters wamesema that was the second time in a week that Baba amesahau mtu wa Ukambani. And Bahati, lazima ujue.
Yes, nazia tumuulize ati wewe unakuanga na mimi juu ya nini? That's now, hiyo ni ufala sasa. That's what I'm saying. Ni wewe mwenyewe ujue. So what really motivates this person to be with me?
When I kama dem ndiye anatoka higher, meaning they are the rich ones, you know, meaning she's the one who was raised in abundance and the guy was raised in survival. There are so many...
For every 349,000 that you deposit or pay as installment towards the any of Optivent's plot of land, you get 10k cash back instantly. Kamata ploti na 349k. Call us on 0790 300 300.
Leadership Forum. We're talking building back better, building health, stronger, resilient health systems. Dr. Nazila provided an explanation for those of us who are novices in the subject on what health systems are. But before we took a break, I said we would be inviting questions from our audience this evening. And I'll start with a gentleman there wearing a lilac shirt. If you could just introduce yourself, and then let's keep our questions concise so that we can get more questions covered.
Thank you. Professor Mohammed Karama, National Chairman of Muslim COVID Control Committee. One of the questions is, I want to thank the speakers for the good, elaborate presentations. One is for the Ministry of Health. When we had about 700 cases in early April or May, 1/3 of them were foreigners from outside, which implied that our port health services did not take adequate measures to control the incoming cases. Secondly, I wanted to ask, and possibly Dr. Akwale will answer this, is it not too soon to relax the benefits that we gained? Before COVID, our hand washing practices were less than 10%. We got up to 80% during COVID. All that is gone because suddenly the ministry unstrategically announced the relaxing of the benefits. I think we need to do something about that. Thank you.
All right, Dr. Kimemia? All right, I'm told ladies first. There's a lady in the back before we get to you.
Hello. Okay, thank you. My name is Doreen Safari. I'm a student at AMREF International University. I'm doing community health. My question is to the Ministry of Health. We have seen how pathetic it was during the time of COVID-19. And also, I'm sure we have had this conversation before about how our government should be doing more, or I'm sure a pandemic can happen or emerge even here in Kenya. So my question is, because we continue saying that we should take measures, we should do this and that, specifically right now, what kind of measures have you taken for the future? Thank you.
Okay, so we'll get into that, I think, in the conversation. You said your name? Yes?
Doreen Safari.
Thanks, Doreen,
okay,
for that question. Dr. Fred Kimemia?
My name is Frederick Kimemia. I work for two organizations. One is the Association of Health System Managers in Kenya. So we run a professional body for health systems specialists, and I also teach healthcare managers at Kenya Methodist University. I want to draw the presenters or the panelists to a saying that says, a bad system will beat a good manager 100% of the time. And Professor Andrew Barasa talked about a healthcare system, and also Dr. Nazira. We providing healthcare services on a health system that is fraud, that is not built on the best practices. Because COVID-19 was a blessing in disguise, according to what I think, because it gave a shock to our healthcare system, and what we saw is our nakedness. The nurses in the villages, the doctors working in extreme, difficult environment. So it taught us that we need to go back to how our healthcare system is designed.
Okay.
Who are the nurses? Who are the managers? How are they funded? How can we look at the design of a healthcare system? And I'm very privileged to serve at a place now we can build health system thinkers, health system managers, people who understand system design, people who can be able to influence healthcare system. So please respond to that.
So I think, Prof. Barasa, you'll take the question on health systems. Dr. Kwale, I'll invite you to answer the question that was raised, two questions that were raised by Dr. Mohammed, including, have we acted unstrategically? Is that what you said, by now lifting these restrictions? Oh, we need a microphone.
Okay, thank you, Olive, and also thank you, everybody, for the questions. Let me start by answering those specific questions by Professor Karama, whom I know has done a lot of work in the area of public health. And the whole issue is diseases moving from one place to another. One of the things, even those early days, the issue was, why did we allow planes to come from China? Why didn't we close early enough? And those were valid questions, but we must also realize we are living at an era where things move very fast. A virus could leave Seattle today and be here tomorrow morning. So all issues of movement, and especially highly transmissible, we must live to the fact that the world now is so much interconnected that as we put in policies and measures, we must realize, yes, we will guard our borders, but we must be alive that we cannot isolate and fully block some of this. And we saw how this pandemic soon became a global pandemic. So for me, the lesson we learned, we need to strengthen our port health services as a surveillance port in terms of early detection, in terms of also being a port of entry for preparedness, in terms of offering isolation facilities. That will be important. But then also the lesson is that we must collaborate with the rest of the globe so that we know which variant is it, and it could even be new viruses. Now, the issue of, did we lift the restrictions too early? The measures that were put, and guidelines along those measures, had other benefits. We saw fewer diarrhea cases. We saw fewer pneumonia cases. We saw fewer. That was a big plus. However, it is so important to realize that once you see these benefits, individual responsibility starts becoming very key. The government cannot police its population throughout. You can't police 50 million people. So we would want to see measures whereby we now convert that benefit into an actual personal responsibility. We must realize that COVID does not infect governments. It infects individual people. So you yourself, you saw the benefit of washing your hands. I think we would want to see that being what becomes the practice now. Yes, we will continue urging and giving education, but more important is, do not wait for what the government will do, but what you do for your own health first and foremost. Thank you.
Okay. So I'll bring in Prof. Barasa. We might not see him here physically, but he is with us virtually. Prof. Barasa, there's a question that was raised by Dr. Kimemia with regard to health systems. And your point was that poor health systems will defeat a good health manager 100% of the time, I think you said. So what do you make of that comment? He described COVID as a blessing in disguise.
Thank you very much for that. And I mean, I think that description is quite apt. I mean, if I can take you back to the African and Kenyan experience of COVID-19, while the infection has really spread across the continent, across Kenya, the burden for the most important challenges, which is severe disease, hospitalization, and death, has been much lower in Africa compared to other parts of the world. And so why is it that African countries have struggled with COVID? And my sense is it's not really a COVID burden problem, but a health system weakness problem. So that's a problem we've been facing. And to give an example, I mean, by March 2020, when COVID hit Kenya, we had only about 500 ICU beds. Now, at any one time, occupancy rate for ICUs is about 90%. And so you're left with, 50 plus or minus beds available. So when you had news about, our ICU beds are being overwhelmed, what you were saying, in essence, is that we have more than 50 patients needing ICU beds. A health system worth its repute shouldn't be struggling with only 50 patients. So really, that comment is very apt. We have to think about strengthening the health system by investing in it, but also have to think about how do we move forward. When we look at our health system, again, across Africa and in Kenya, there is an emphasis on secondary care and tertiary care. So a lot of resources go to hospitals, while actually what we need is for these resources to go to the primary health care and also go to what we call close to community care, so community health workers and so on. What COVID showed us is that if we do not use our community health systems, our health system is going to be overwhelmed. What saved Kenya is one of the things that really saved Kenya is the fact that Kenya implemented a home-based care approach, which was quite innovative, but it allowed the health system not to overwhelm the hospitals. So what we should learn from that is that we need to invest and prioritize our community health systems if we want our health system overall to be resilient to COVID-19. So that's one lesson about reorienting health systems. But we also have to realize that investing in the basic aspects of the health system, making sure that health workers, we have adequate numbers of health workers, making sure that the health workers are protected, and also making sure that health workers are motivated to do their work.
Okay.
It was quite weird to see health workers going on strike during a pandemic. But the reason that happened was because they were not protected, they felt they were not adequately protected and safe, and they were not adequately motivated because they're not getting their salaries on time and so on. Okay. So we really have to take this thing seriously.
All right.
We are to have health systems that are going to respond to pandemics.
Okay, thank you, Prof. Barasa. Prof. Osur, you whispered to me that you want to contribute to this.
Yeah, the whole issue of the system and the managers, I think is very apt. A good manager is beaten by a bad system. But we need leaders, because leaders are the ones who develop the system. They make transformative decisions. And I think the problem we have maybe in Africa is that we have weak leaders, which lead weak systems. Because leadership means transformative decisions. If it is not working, then we look for what works. We look for it and we change to what works. And I think it is that which is lacking. Yeah.
Okay.
The managers are there.
Okay.
And we always make assumption, if I'm a good clinician, I can lead the health system. Those two things are different. We need leaders to transform health systems in Africa.
Okay.
To be strong.
Okay, we'll get deeper into that conversation on leaders, because now I'm like, how do we identify these leaders? All right. We have Dr. Feni joining us from Ghana as well. I hope you haven't forgotten her. Hi, Dr. Feni, you still with us?
Yes, I am.
Oh, good to see you.
I'm listening very carefully, and I can see a lot of commonalities across our countries. Sometimes I can't even believe the examples are just like what we have here in Ghana.
All right. So I see
very closely.
So when I was reading your very long credentials, I saw you are Commissioner on Africa's response to the COVID pandemic. What are we doing as a continent to prepare ourselves for the eventuality that should another pandemic hit us, we are better prepared?
Okay. So I'll put that hat on and talk a little bit about some of the strategies that we think we should be looking into and investing. We have several of them. We have several subcommittees working on these recovery programs, but we flag a lot of issues that we think are very critical to prepare us for the next pandemic. So funding becomes very key. We recognize that we need to have a way of closing the funding gap. And you know, the question about the private sector, how do we engage the private sector so that we can benefit from investments from private resources, which is so much needed, you know, as we wean ourselves off external funding. So that is one of the pillars. We are also looking at the health workforce. I remember as Prof. Barasa was speaking, he mentioned the empowerment of the workforce. You know, if we do not motivate our workforce, we will lose them. We've seen a number of our workforce leaving to greener pastures, and you can't blame them. You know, economically, they want to have better lives for themselves and their families. But we need to start looking critically at how we can build the capacity of our workforce, invest in them, motivate them, keep them empowered so that they will serve and continue to serve. And also encourage the younger ones that are coming to move into the health profession. If we do not do that, we will have a generation that has no interest in the health system, which will make it even worse. So funding is key. Healthcare workforce is also very critical. We also talk about investments in vaccine production. I mean, we've seen what has happened to Africa as a whole when it came to access to vaccines. You know, we were very late to get onto that table, by which time others have taken the lead. And so investments in our own locally produced manufacturing industry, very key. Getting the right markets for these manufacturers if they actually get established, so that we'll keep them working and motivated to continue to produce locally. So we also talk about governance and leadership and where we place, you know, every country is different, but we can learn from each other. So one of the things we're doing as a commission is to put together what we've learned, what has worked, what hasn't worked, you know, and engage the whole continent through our different task forces, you know, to come up with a new public health order that all countries will work towards. Okay. And so that we will not be taken by surprise if there's another pandemic. So these are some of the things that we're doing as a commission.
Okay.
Thanks.
Okay, Dr. Nazila, I hate to throw you a curveball, but I'm going to throw you a curveball. We had about this issue of health workers and motivation, and there was a time even, there was talk about forming a health commission, and there was resistance at some point to devolving health as a function. So that has already happened. We have devolved the health function, but do you think we still need a conversation around a health commission, and how do you address the problem of this brain drain? It's brain drain, right? Our health workers seeking better opportunities outside the continent.
Thank you very much. But before I dive into that question, I just wanted to add to what Prof just mentioned about some of the areas in which we need to look at should another pandemic come. In Kenya, we have a legal notice which has established the Kenya National Public Health Institute, which is actually mandated and tasked to, you know, prevent, monitor, and then respond to such outbreaks, public health outbreaks. And so therefore here we are looking at really the health worker trainings as well as the surveillance, I mean robust surveillance, and also so that we could be able to respond to this in a quick manner, because really we can just say it's like a magic bullet to be able to promptly respond to this. Coming to your questions of the Health Service Commission, I think it is very important that we should actually have that so that the healthcare workers are all governed centrally, and we could be able to also have the grievances and also look at the opportunities they can have maybe for trainings, and also really deploy them where the need is according to their skills. Right now, all counties are actually just having their own pool of experts, and you know, sometimes we can see that a particular cadre is maybe in a far-off county and really needs to sort of, maybe he's not being utilized really effectively there. And so if we had this Health Service Commission, then it would really be able to maybe manage how a particular specialist can be able to work within different counties to provide the much service needed of which he has been trained for. So that is very important, and really it would be a boost to the healthcare worker, and that's what we're looking forward to.
Okay. Prof. Osur, how important is this conversation around health workers? At some point we brought in Cuban doctors after our own health workers have numerous times. I think Prof. Barasa talked about health workers going on strike during the pandemic. How critical is addressing these concerns where health workers are concerned? How critical is it to health outcomes in general?
Yeah, thank you. It is very important. And I think sometimes when we talk about health workers, people think we are only talking about doctors and nurses. I think there are over 40 cadres of health workers. There are many problems. Some are not even recognized, and yet they are the backbone of the health system. Take the community health workers, for example. You cannot control a pandemic or an epidemic without them. They work directly with the households, but we don't recognize them. We call them volunteers. It means that they have no responsibility on what they do because they are volunteering. We don't want to pay them. So we have to recognize all cadres and then look at the deficiencies we have. We need numbers, definitely. We need better distribution. They are more distributed to the cities than to the rural areas. But coming now to the ones that people think about so much, the doctors and the nurses. During COVID, one thing that was very sad in many countries is that they were going on strike. And people thought they were very insensitive. But I think there was a lot of frustration. And a lot of people felt they were not recognized and they were suffering. And one failure that we have is that we don't have psychological support for these frontline soldiers. So a doctor and nurse will be handling many patients suffering. They'll see death, they will certify death, and then walk home and nobody is supporting them. Psychological support, very important. I was in Uganda the other day, and the nurses were asking in a meeting, are we going to be compensated? In other words, people are saying, can you recognize what we do? I think it's not even about money. It's about appreciation that we see what you are going through. You are doing a great job. We want to support you. What can we do to make you feel more comfortable? Just that. Because some of these professions, they are a call to service. It's like being a pastor. We have a pastor in the audience.
We do?
Yeah. Health workers, it's a call. You can never be paid for what you do. But what they need is an appreciation and someone saying, we realize you've worked for 18 hours continuously. We are giving you transport to go back to your house and rest.
Okay. So on that note, we are taking another break. But can we give our health workers a hand clap as we take that break? We appreciate you. Do share your thoughts, your contribution to this conversation. The hashtag is Build Back. Build Back Better. We'll be better on the other side of this break.
Choose boldness. Celebrate the skin you're in and dress with confidence with Nivea Nourishing Cocoa Body Lotion. The triple-layered care of deep moisture serum, precious cocoa butter, and vitamin E enriches your skin for 48 hours. Choose to wear your skin with pride with Nivea.
How do you keep your toilets clean? I use normal detergent and bleach for washing. The detergent and bleach cleanless can leave behind yellowness, rust, and germs. Harpic's 10 times better cleaning compared to regular detergents and bleach, and kills 99.9% illness-causing germs in your toilet, including the COVID-19 virus.
You do your best out there, let us do our best in here with the disinfecting power of Jake. Because Jake cleans and kills 99.9% of illness-causing germs and COVID-19 in your home. Jake, your family's guardian against germs and COVID-19.
A lion!
Ah, yes, the king of the jungle. Time for a Red Bull.
Red Bull? Still, you'll never be faster than a lion.
I don't have to be quicker than the lion, just faster than you.
Red Bull gives you wings. This could be you, your sister, brother, daughter, son, or a friend. Say no to gender-based violence. Report any form of violence to toll-free number 1195 or to the nearest police station. Be a hero and be safe. This message is brought to you by the government of Kenya. This is NTV.
Tonight, the dam loans and their repayments. Kenya has defaulted on billions of shillings in loan repayments for 3 dams. We have the damning details. Also tonight, Martha is not mincing her words as her opponents seek to dismiss her.
Kama uko na pesa, badala ya kutuma vijana, ingia wewe. Kuja unipokonye microphone.
Nimeona vile Martha ametembea Kirinyaga, mambo ni magumu. Ametembea Meru, mambo ni magumu.
The political temperatures are rising. The heat is on. Then, Gideon Moi has an assignment, wooing Kalonzo right from his farm and family into the Azimio corner.
Kalonzo Musyoka akienda agombe kiti peke yake, hizo kura ni za kuharibu.
And also tonight, police say the Mirema shooting victim was a serial thug with 7 wives who had been arrested more than 30 times. So what's the story here?
We asked Kenyan women to tell us what they look for in a lotion. Ladies, what is most important to you when buying lotion? Smoothness, scent, glow. Today, we are testing an expensive body lotion versus an affordable one. Ungenunua gani? Why pay more? Get great quality at an affordable price. It's just nicer and lovelier. Chagua Kenya's #1 body lotion.
Panadol Baby and Infant starts to work on fever in just 15 minutes. Trust Panadol Baby and Infant to work on fever fast to bring back their cute smiles.
Jina langu ni David Waku, mimi ni professional golfer. Namshukuru sana baba yangu, alinijulisha kwa mchezo wa golf na kunipa ujasiri wa kuwatambulisha wengine kwa mchezo huu. Nilipoanza nililenga vizuri nafasi yangu na kuonyesha ujuzi na kutimiza ndoto zangu. Mwanzo nilitishika, lakini nilipopata nafasi ya kucheza mchezo huu maridadi, nilipata ujasiri wa kuutumia vyema. Kama yalivyo maisha, golf inahusu uvumilivu na udhabiti. Ili kushinda, nilihitajika kuweka juhudi na kufanya kazi kwa bidii zaidi kuliko wengine wote. Uwezo wa kuwa bingwa ulikuwa ndani yangu, na kila nilipolenga na kupiga, ndivyo nilizidi kukaribia nia yangu ya kuwa mfalme wa mchezo huu.
David Wahu alibadili kila jaribio lake kuwa fursa. Anza safari yako mwenyewe ya mabadiliko katika Safaricom Golf Tour.
When cooling down is easy, this easy. Nice. You even took it with a smile.
What about yours?
And we're live, coming to you live from the AMREF International University, continuing our conversation on building back better, stronger, resilient health systems. So I'm going to start with a few questions from our audience. We'll take one from Oliver. I'm not sure, do we qualify as namesakes? So I'm told you are the pastor that was made reference to from the stage, and then we'll take one from a student, and then we'll take a question from social media. So go ahead, Oliver.
Thank you, Olive, for having us. I come from Korat, Africa. Our niche is to support management training for mission hospitals. And I just wanted to say that a very strategic lesson that comes out of COVID is that actually we are investing a lot of money in preventative diseases. And that if we can emphasize a little more on the washing of hands and others, we can do away with an entire budget that occupies our nurses and doctors, and then focus on the more critical areas that actually might not be helped by washing of hands and others. And so I'm just wondering, in terms of strategy, what are we thinking? And the second thing is that Prof. Joachim just mentioned about the rural facilities where we missionaries operate. We are most of the time first line where the public comes to as they are seeking support. They could be referrals to the rest, but is there a significant partnership that seeks to harness those facilities and equip them in such a way that they can actually support the system?
Those are faith-based organizations?
Yes.
All right.
Yeah.
So I was told we had a question from the students in the room. Okay, there's a gentleman there in grey. Unfortunately, we won't be able to take all the questions right now, but there's a gentleman in grey at the end there. As you get that mic to him, let me, Onyango? Sorry? Somebody really has a microphone. Oh, okay, who is it? Okay, yes? Student?
Yes.
Okay. I'm sorry that you've been overtaken, but the panelists are here to stay for a bit longer after the conversation. Yes, go ahead.
Good evening, everyone.
Good evening.
My question goes to...
Your name?
My name is Damaris Katumbi Wambua.
Nice to meet you, Damaris.
I'm a student here in AMREF International University.
Studying?
Pursuing BSN, nursing.
Okay.
My question goes to the Ministry of Education and the Ministry of Health. Okay, the Ministry of Education by extension. The pandemic came to us as a shock, even the health workers included. My question is there a need to incorporate pandemic preparedness in our healthcare training colleges?
And you bring me to an interesting question, because there was actually a question that came through on my phone about research and innovation, and what has the COVID pandemic spurred in that regard in the medical community in Kenya. I know we began manufacturing PPEs and sanitizer, but also Kenya is among the countries that were named by the WHO as far as manufacture of vaccines is concerned. In terms of research and innovation, as AMREF International University, what has it encouraged you to do? KU, I think, came up with ventilators. I mean, KU started producing, was it KU? And it was ventilators, if I'm not mistaken. So you can address her question, one of your students. Okay, and let me just come in with a question off of social media. And let's see who is best suited to answer this question. The question is, the pandemic came as a shock to everyone, even health workers. Is there a need to revise our health curriculum to include training on pandemic preparedness in health programs in our colleges?
Yeah, thank you. I think that's a good recommendation, not actually a question. But in terms of innovation, I'm talking about AMREF and AMREF International University. We are a partner of Africa CDC, and we've been able to roll out virtual training for community health workers and other frontline workers in COVID prevention. So at the time when people could not congregate to be taught in classes and things like that, we have a platform which is easy to roll out on mobile, and we've trained in many countries, and that has helped a lot in having the frontline, especially community health workers, get knowledge to be able to take off immediately the pandemic started. And you remember also, innovation goes even up to the level of evacuation. AMREF flying doctors, just, you know, shipping ventilators all over the place, vaccines, test kits. We have been very busy doing that. And I think there are a lot more other things we are doing, even at the health facility level, coming up with models that can help provide other services that have been there, while at the same time taking care of COVID patients without infecting other patients and health workers. So we have those models which we have innovated. So innovation is not just technology, it's also the models of service delivery, it's also the models of how you do procurement and supplies and all that. We are much involved in those things, yeah.
Okay, all right. Dr. Nazila, where are we on the road to recovery? We saw, like we talked about these indicators earlier on in terms of how TB was impacted, malaria, zero HIV/AIDS. We've made a lot of commitments internationally as far as that is concerned, and they were impacted during the COVID-19 pandemic. So where are we now on the road to recovery?
Thank you very much. So, you know, in order to ensure that we do not reverse the gains that we have made over the years with this disease programs and other disease programs as well, we have ensured that we have catch-up sort of strategies in order to be able to catch up on like the indicators which have really fallen. For example, in terms of like routine immunization, because of the fear of patients actually coming to the outpatients to look or to actually get the services, we saw that most of the indicators for vaccines had also, I mean, routine immunization, as with other indicators across the essential health spectrum, had also fallen. So we are now in the process of course, catching up, and we are having like the rapid catch-up initiatives, such as like recently we had a HPV vaccine campaign so that we could be able to really catch all the children who have missed out on this. In terms of, for example, in the HIV program, we really, in terms of, you know, the ARVs which were given to the patients, those indicators were not really affected in terms of the consumption, because we had innovated, and we had some innovations which were done then. That is the multi-month dispensing, where we had given the patients medications for a couple of months to cover them, so they do not have to come back to the facility. Also, on the same platform, we had sort of like a telemedicine or call center sort of, called Mshauri, where the patients would actually always communicate with their healthcare worker to ensure that their services are not interrupted as well. I mean, have appointments to come and visit at the health facility. So these are always coming up. And these strategies we have put in place so that we do not really reverse the gains. In terms of TB, we are ensuring that from now henceforth, whenever we are going out there to find missing TB cases, we are also going to be testing for COVID. So because there's similarities in the symptoms, we don't want to miss out cases, TB as well as COVID. So those are some of the things that we're looking at. Okay. I know in terms of Prof here was talking about some innovations as a country that we have made. I'd also like to talk about the hospital beds, which I think the Juakali sector had really made once we were procuring some of those. Another innovation which is really important is the Chanjo KE system, which we used during the vaccine deployment of the COVID-19 vaccine, which gave us real-time data, the uptake, and also really we could make, as a task force, we could be able to make a decision based on that, on the data which we're getting real-time. We also had, of course, innovations with telemedicine, but also in terms of because the vaccines, we're also looking at the safety aspect, especially the adverse events following immunization, if anyone had any of those IFEs.
Okay.
Normally, the Pharmacy and Poisons Board would have physical forms to fill, but in 2021, they really rolled out the electronic system, the PVRS system, and much recently, they have rolled out a USSD code and also an app so that it is easier for the public and the common wananchi, all of us, to be able to report these side effects when they occur very easily, instead of going to the manual system, going back to the health facility. And this kind of innovation really helps us to make a decision as a country.
All right. So let me bring in Dr. Feni and Prof. Barasa to give us the last word on this subject. How do we leapfrog this inequality? I think Prof. Osur highlighted the inequalities that COVID-19 exposed in our health system. He talked about 2 health systems. Let's start with you, Prof. Barasa, briefly, if you could.
Thank you very much. I mean, the way you address inequality is by asking yourself, where does it come from in the first place? And there are so many places, we can't talk about all of them tonight, but I'll just highlight some. So for instance, you get inequalities from the way you finance your health system. If your health system is based on out-of-pocket payments, then people that have ability to pay, so the well-off in society, are going to be the ones that are more likely to access care, as opposed to those that are less well-off. When the way you finance health insurance, for instance, is by depending on people to make monthly contributions. And again, the people that are going to do that are the people that are well-off, and those that are less well-off are likely to do that. When you focus most of your resources on hospitals, so higher level care, hospitals and so on, and neglect your peripheral facilities in the rural areas, then again, the people that are going to access services are likely to be those that are in urban areas and are well off to pay for hospital services. So addressing inequality is really about tackling all these structural issues that bring about this inequality. It's about shifting the health system to get closer to the community. It's about making sure you provide financial protection for people so that people are actually accessing healthcare services because they need them, not because they can afford them. When you orient your system that way, then you begin to address the inequalities.
Okay. Dr. Feni?
Okay, thank you so much. So I was really happy that there was emphasis on prevention. The fact that we need to really finance our preventative initiatives, it will save us a lot of funds that we can reallocate to certain aspects of our health system. But then the key is, how do you change people's behavior? How do you make it routine for people to take care of their health, to routinely check on their health status? We have people who have hypertension and they have no idea they have this. So how do we make that behavior change normal in our communities? That's one. And then I remember that when Prof. Osu was talking about distribution of health facilities across our cities, it took me back to the results of our latest population census. So if you look at the proportion of rural to urban in Ghana, in 2010, we had about 68% of our population being rural. Now that has decreased to about 43%. So the question is, Where are all the people who have moved from our rural areas? Are we targeting the urban areas that are spreading all over the place with good quality healthcare? And the urban poor, most of the time, are left out of our health interventions. So we really critically need to look at some of these outside of the health sector issues that need to be considered. Okay. You know, population change, population shifts, population growth. They all have a part to play in how we design our health system and how we even finance our health system.
All right.
So these are the two things I need us to reflect on. Okay. And it all stands on data, data, data. We are not investing in research and development enough. We really need to find the data that is needed to make our policies work. We cannot continue to have ad hoc policies. It will not work.
Okay.
You know, so let's invest in our data system. That is very key. Thanks.
Okay. So if I was to print what she said on a T-shirt, it would be data, data, data. Dr. Lwale talks about governments don't catch COVID. People do, personal responsibility. I think if I was to put what you said in a snippet, it is leadership. Leadership needed in as far as management of health in this country is concerned. Dr. Nazila, what is your parting shot?
So my parting shot, well, it's not really about the health systems at the moment. My parting shot would be that we are still vaccinating the population. And I'd urge all the members who have not been vaccinated, the first dose, booster dose, to please come out in numbers. We are not out of the woods yet. We need to get vaccinated because that is the only way we'll resume back to the real normal that we really know. Okay. So the vaccines are available in all facilities. And yeah, it's a quick thing. Just get the vaccines.
Okay, Professor, as our host, wind it up.
Thank you. I really feel we are now at a good point to take stock. And I'm hoping that the Ministry of Health in Kenya and in other countries will convene just to look back and say, these are the lessons we've learned, these are the things we need to change. We are still doing the same old thing. As COVID eases off a bit for now, I think nothing has changed. Health facilities have remained the same. So I hope the ministry is listening and you will convene us and we can share lessons and say it should never be the same. Okay. And finally, that we give more responsibility for health to other ministries as well. We've learned that collaboration, multi-stakeholder involvement in health is what we need.
Okay, and I think that's the point my namesake made. All right, ladies and gentlemen, that brings our conversation this evening to a close. Zainab Ismail is waiting on the other side in studio at the Nation Center to bring you the news at 9 p.m. sharp. So why don't we give our panelists a hand clap? Give yourselves a hand clap. You have been fantastic. Dr. Feni, Prof. Barasa, thank you so much, Professor. Dr. Nazila, I've been your host. This is Olive Barros. And this is a conversation we cannot possibly cover in 1.5 hours or less, given the commercial breaks, but it continues online.